Good morning, ladies and gentlemen. The topic of today is the male genital system. The male genital system can be divided into two parts, internal and external. Internal is hidden inside the body, even testis is outside in scrotum. Testis is considered as the gland, the gonade, and it's within testis together with epididymis, which is already beginning of the excretory male genital tract. The male genital tract then continues as a deferent duct inside spermatic cord, and it receives the excretory duct from vesicles gland or seminal gland. Then it enters urethra inside prostate, receives a duct from a small bulbourethral gland, and then it gets out to the external male genital organs, which are composed of penis and scrotum. So then the semen goes inside urethra to the very end, to glands of penis. And all the organs are located at the pelvic part. So it concerns outside the pubic and perineal region for penis and scrotum, and the rest is contained inside the lesser pelvis. So we can start with testis, in English testicle, in Greek orchis, and you can hear the term orchis in the name of orchideas, which are plants, and their root reminds of the testis. So testis is a gonade, and it's an egg-shaped gland. So externally, you can easily describe superior pole and inferior pole. So superior and inferior pole. Then two margins, anterior and posterior, and it's a bit flattened, so that two testicles can be located inside scrotum between two thighs, so that we have a medial and lateral surface. The surface is quite smooth, and it is covered by peritoneum, a derivative of peritoneum. It is called tunica vaginalis, and it has got, as every serous membrane, two layers: a parietal layer, which forms the wall, and the visceral layer, which covers the testis itself. And in between is a cavity called vaginal cavity. How peritoneum gets to scrotum? As testis develops from the intermediate mesoderm at the level of L2, that's why also the vessels comes from the level of L2 from abdominal aorta, it descends. And independently on this descent, also a pouch from coelomic cavity develops. Both structures enters the inguinal canal, and the pouch, so-called vaginal process of the peritoneal cavity, is located more ventrally. So that then the testis takes it down and push into its posterior surface. So finally it is totally covered from all the sides except of the posterior, small posterior part. And it forms, that's why, a small cavity. The communication between the peritoneal cavity and this vaginal cavity then disappears, and remains only as a connective tissue cords, which are called vestiges. So that's why in male we can find 4 serous cavities, unlike female where we have only 3. So this is the surface. When we come below the tunica vaginalis, there's tunica albuginea. It's a really tough connective tissue, which is whitish. That's why the Latin term albus, albugineus, whitish. So testis is fixed inside scrotum by 3 ligaments. 2 are very small and they just fix testis to epididymis, so superior and inferior epididymal ligament, and a scrotal ligament here, number 15, which is located caudally, and it's a remnant of fetal tissue. It is called during the embryonic and fetal period gubernaculum, which means a steer of a ship, and by means of testosterone, this part of connective tissue is reduced and shortened, and this causes the descent of testis and ovary as well. So the glands then descend by retraction of this gubernaculum, and finally the gubernaculum is so short that it forms only this short band between the inferior pole and scrotum, and it's called scrotal ligament. Why testis is outside the main body cavity and it's located in scrotum? The reason is a lower temperature by 2 to 4 degrees of centigrade. And the reason is that some of the enzymes during formation of sperms needs a bit lower temperature for their precise and appropriate function. So when we come inside, for example, here on a sagittal cut, we can see the parietal layer and the visceral layer of tunica vaginalis, so peri and epiorchium. In between is a cavity, the vaginal cavity filled with a little bit of fluid. Then we have the whitish tunica albuginea, and the tunica albuginea sends these septa or septulae. And the septulae meets in connective tissue, which is here, and this we call a mediastinum of testis. Each septulum then forms a lobulus, and there are 200 to 300 lobuli, and then contain 1 to 4 contoured seminiferous tubules, which are quite long. And when you measure all the contorto seminiferous tubuli in one testicle, then the total length is half a kilometer. So you can see it's a tubular composed gland, and the epithelium inside the tubulus is very special. It's a complex pseudostratified epithelium. It's unique in the human body, and it's called spermatogenic or germinal epithelium. So then when the sperms are formed, they continue through very short straight tubuli, so tubuli recti. Then these straight tubuli, they form a network called rete, and then it continues into epididymis in so-called efferent ductuli, and then they continue as ductus epididymidis, which is then convoluted here and continues up as deferent duct. So below tunica albugina, which is, as I said, very thick and is composed of connective tissue and sparse, smooth muscle cells, we can find tunica vasculosa. Tunica vasculosa contains capillaries, and from these capillaries, another ones continue into septae between seminiferous tubules. So how one tubule looks like? As I said, it's a complex tubulous gland lined with spermatogenic or germinal epithelium, which is a complex pseudostratified epithelium. As you can see, very different kinds of cells can be visible here. It's quite high, the epithelium. It's 80 micrometers high, and the whole diameter is 200 micrometers. The main cells are so-called Sertolys cells. You cannot see the borders, but you definitely can see a beautiful nuclei of these cells, which are the scaffold and nursing cells of all types of developing sperm. They sit on a basement membrane, and below the basement membrane is a peritubular testicular cell or myoid cell, which is a typical myofibroblast. And these myofibroblasts, they allow constriction of the tubules and movement of the sperms. And then is a thin fibrous layer, so something like adventitia. Of course, the most important cells are the spermatogenic or the germinal cells. We have several types of them forming the spermatogenic epithelium. It's a topic of histology, but we just go slowly through them. As I said, it's a pseudostratified epithelium because we have the Sertoli cell, and the Sertoli cell is like that. So you can see it comes from the basement membrane up to lumen. But the other cells, the different stages of sperms, they form layers, so 4 to 8 layers. And the basic cells are located here in so-called basal compartment. And they are the stem cells, and we call them spermatogonia type A. And these spermatogonia type A, they undergo mitotic division and into a spermatogonia type A and B. The spermatogonia type A stays there and again multiplies, and spermatogonia B then passes into so-called adluminal compartment. Why do we need two compartments? Spermatogonia are here from the beginning of the development, so their antigens are known to the immune system, and the immune system do not fight against them. But then the spermatogonia B, which then changes into primary spermatocyte, and the primary spermatocyte undergoes meiotic division. Then what happens that the chromosome equipment is then changed, so the immunity and the antigens are changed. So it's already considered as a dangerous or a body alien structure, and that's why it has to be located in different compartment and divided by so-called hematotesticular barrier. I'll come to that later. So that's why you have two compartments. So back to primary spermatocyte, which is the cell with largest nucleus, and it stays there approximately 22 days. So it stopped in prophase in the first meiotic division, and then it continues and changes into secondary spermatocyte. The secondary spermatocyte is there very short time, and it undergoes the second meiotic division and changes into so-called spermatid. The spermatid is then slowly changed into sperm. As you can see, the most important changes are the morphological changes, mainly formation of flagellum and acrosoma. Acrosoma with enzymes and flagellum here. And it takes approximately 64 days, so it's called spermatogenesis. And here we can nicely see the different types. So I start with the Sertoli cells and its nucleus, which you can see here. then the spermatogonium A and the B. The B then changes into primary spermatocyte, and here we have the hematotesticular barrier. So this is the basal compartment and adluminal compartment. So primary spermatocyte then changes into secondary spermatocyte. So we have the first and then the second meiotic division, and we have finally the spermatid, which is then released as a sperm into the lumen. Here we can see also the myofibroblast or the myoid cell or peritubular contractile testicular cell, and then the fibrous layer. It then contains the interstitial structures like capillaries, fibroblasts, mastocytes, and also these very important interstitial cells of Leydig, which produces testosterone. When we come to hematoxylin eosin stained slides, here on the surface we can see the tunica vasculosa, and then the convoluted seminiferous tubule, and the interstitium in between. And closer, here myoid cell or myofibroblast, and the largest cells are the primary spermatocytes, which you find first, and nicely see the spermatogonia. They are lighter. Here spermatids can be easily visible as well, and the nuclei of Sertoli cells are here. So the Sertoli cells, as I said, they are nurses forming scaffold. So they cover all the stages of the spermatogenic cells during their development. They are quite long, cone-shaped, and the nucleus is located basally. So they form the hematotesticular barrier. To form such a barrier, you need to form a tight junction. So there are tight junctions, and they divide the basal compartment and the adluminal compartment with specific environment to separate all the developing stages but spermatogonia type A. Here we come again to the detail, a nice detail, so we can see the myoid cells here and the Sertoli cells with their nucleus located basally here, and the spermatogonia type A and B. You can see the difference in their nucleus. And then we continue via spermatocytes type 1, which are the largest cells, to spermatocytes type 2, and then to spermatids, which then are released into the lumen. And in the interstitial layer, we can see the blood vessels here, but also nicely the Leydig cells producing testosterone. Here we can see scanning electron microscope figure showing us again the spermatogenic complex pseudostratified epithelium, and nicely the Sertoli cell from the basement membrane going up here and then back. Yeah, these are the walls of the Sertoli cell. And we can see that, of course, here's nice myeloid cell. And we can see the different types of spermatogenic epithelium cells. So spermatogonial here, spermatocyte, primary spermatocyte already in adluminal compartment, spermatocyte type 2. So after first meiotic division, and spermatid after second meiotic division, with acrosomal vesicle already and flagellum. So what is the function of the Sertoli cells? As I said, it's scaffold, so it forms support and nutrition, so it feeds all the types of the spermatogenic epithelium cells. During the development, some parts of the sperm are not necessary anymore, so they are reduced and removed by phagocytosis, and so they are so-called residual bodies. So that's another function, is phagocytation. It produces testicular fluid, and it secretes several proteins. One of them is androgen binding protein, as it binds testosterone inside the adluminal compartment, and it elevates its level, so it's very necessary for the proper development of the sperm itself, also inside the tubular lumen. Then as the Sertoli cells, their function is maintained by a hormone from pituitary gland from its anterior lobe, so-called adenohypophysis, and it's called follicular stimulating hormone. So this follicular stimulating hormone increases the function of Sertoli cells, but the Sertoli cells can produce inhibin, which regulates the secretion. So it's a negative feedback regulation. During the development, it also produces so-called anti-Müllerian hormone, which causes fading out of paramesonephric duct of Müller, which is a base for female excretory genital organs, so for uterine tube, uterus, and part of vagina. And in female, this duct is not necessary anymore, so that's why it's made to fade out and disappear. The Sertoli cells are very, very resistant, so they do not divide, and that's why they also can survive even radiation. So concerning the spermiogenesis, let's just talk about some important dates. That it takes some 64 days to be produced, and then another 12 days which it spends inside the ductus epididymis. So how does sperm looks like? There are many terms for one sperm, so sperm cell, or a male gamete. And in Latin we use the term spermatozoon as well. It's quite long one, and the longest part is so-called principal part, which is inside, which is the main part of flagellum. Of course, the most important part is the head, and in the head we have the genetic information, nucleus, which is haploid. Then we have the acrosoma. Acrosoma is a vesicle containing very important enzymes like hyaluronidase and acidic phosphatase and so on to allow the sperm to pass through zona pellucida and corona radiata of ovum in a female genital tract. So that's acrosome, which means part of the sperm which is at the very end, acros. We have a neck, and the neck contains centrioles, and the centrioles here are mainly for production of the axonema, which is the main structure of the flagellum to allow the movements. So that's the neck, and then we have the flagellum, and the flagellum consists of three parts. One of them is called the middle piece, intermediate part, which is fed up with mitochondria. So that's the power station of the sperm. And then we have the long principal part and the very, very short terminal part or end part. So that's the whole sperm. And the development of the sperm is shown here. As I said, it's a topic of histology, just to show you how the sperm really changes and how the acrosoma is formed as a vesicle, which then moves slowly to the very tip, and finally it forms the acrosoma here. Yeah? And then you can see also how the proximal and distal centriole forms. They stays in the future neck, but they forms the axonema, which is the axis of the flagellum, and the development and movement of mitochondria into the middle piece, which is part of the flagellum then. So when the sperm is matured, then so-called emission starts, and the emission is the movement from epididymis to prostate, and then when it enters urethra, it is called ejaculation. So when the sperm is ejaculated into female, it is still not capable of fertilization. So it has to undergo a process called capacitation, which takes several hours, and it means to remove a cover of the acrosoma, yeah, from the acrosomal surface. So the acrosomal reaction is then the action of mainly hyaluronidase and acid phosphatase and other enzymes and acrosin, which enable the sperm to pass through the corona radiata and zona pellucida of the ovum or oocyte. And one sperm is viable more than 2 days, but the oocyte, after the mature Graafian follicle ruptures, is viable only for 1 day. So there is a really short period in which the fertilization can happen. So that's all for the sperms, and a bit of the Leydig cells, which are the interstitial cells with endocrine activity, producing steroid hormone called testosterone. This testosterone is influenced by pituitary gland again, by its anterior lobe, adenohypophysis, by so-called luteal hormone, LH. Yeah, the Sertoli cells were influenced by follicular stimulating hormone, and the Leydig cells by luteal hormone. What is important that it is active already from the 7th to 8th week of the intrauterine life, and the embryo needs it for differentiation into a male. So the internal and external male genital organs can appear, and also the female one can be reduced. Except for Leydig cells, we have inside interstitium capillaries, fibroblasts, the mast cells, and macrophages, and of course some collagen fibers. You can nicely recognize them as having a really large and eosinophilic nucleus with prominent nucleolus, which means that they are steroid-producing cells. And this is how you can see it in your own slides. So a seminiferous tubule here, and then the Leydig cells can be visible in the triangles between tubules. And in here, for example, here is a Leydig cells. So now we can move the sperms outside the body. So they have been produced in convoluted seminiferous tubules, and they are slowly moved by production of the testicular fluid and by contraction of the myoid cells. So they slowly continue into very short straight tubules, which we call in Latin tubuli recti. They are lined with simple cuboid epithelium, but at the beginning they are even lined by Sertoli cells. And the epithelium is then protected by a very thin layer of connective tissue collagen fibers, so by lamina propria. These short tubuli recti, they meet in a network, they are connected, and they form within mediastinum testis the rete testis. Again, we have cuboid epithelium, sometimes the cells are even low columnar. Now the speed of sperms has to be elevated, so we have kinocelia be here, but not many, only one kinocilium on one cell. And this is the place where they leave testis and they enter epididymis, which is only a system of canals lying on testis but being morphologically separated. The first structures are called efferent testicular ductules. Yeah, these blue ones. They are called efferent ductuli of testis, but they are all already located inside the head of epididymis. So that's important. Morphologically, they are already in epididymis. They are lined by cuboid to columnar epithelium, but it is pseudostratified, because you can see sometimes a double row of nuclei. So you can see the small basal cells and then the high cuboid to columnar ones. And we can distinguish in these higher cells the cuboid cells with microvilli and columnar cells with kiniocelia. Already more kiniocelia are here. So then the movement is a bit quicker. The number of these canals is 10 to 20, and they are quite long, 20 centimeters. And the movement of sperms is also maintained by one layer of smooth muscle cells and elastic fibers around. So you can see that even these small ductuli has got typical three-layer arrangement with mucosa, containing this pseudostratified cuboid to columnar epithelium and lamina propria, a very thin muscle layer, which means one layer of smooth muscle cells and elastic fibers, and tunica adventitia, which is the loose connective tissue around. And we can continue into epididymis, which contains again a pseudostratified epithelium, and here it's really high columnar with stereocilia. It's important, here are stereocilia. And you can see it's one many times coiled tubule. And it's lined with several cells. Of course, we have the basal cells, but then we have the so-called principal cells featuring stereocilia. So no kinocilia. Here the movement of the sperms is stopped for several days. So what we need is to stop their movement, and we perform it by acidic environment, which is assured by hydrogen 8 APAs. The sperms here, of course, for these 12 days has to be fed. So another function is the nutrition of sperms by glycoproteins mainly. If there is no emission and ejaculation, the old sperms has to be removed. So phagocytosis is very important here. Of course, the sperms are haploidic, so they are alien to the immune system. So we have here also a barrier, which we easily call hematoepididymal barrier. So the principal cells form the barrier. And to prevent the sperms not to capacitate, their surface is covered by surface associated decapacitation factor or protein, which is covering that, and it is finally removed in female genital tract. So that's the final function of the principal cells, to feed them, to get rid of old ones, and to save them by hepatoepididymal barrier, and to stop their function by surface-associated decapacitation factor. Then we can find some immune cells basally having a light corona around, so they are called halo cells. And then there are cells which serves also for removal of proteins, and they are called light and slim cells. So that's the mucosa. Of course, below mucosa lamina propria, and again another two layers. So a muscle layer formed by smooth muscle cells and tunica adventitia, so loose connective tissue. So that's the epididymal duct. And then when the emission starts, it continues as a deferent duct. So the deferent duct is again a pseudostratified columnar epithelium with stereocilia. But then the movement is really, really quick, so we need a thick muscle layer, 3 layers. I'll come to that later. We come to the end of the deferent duct, which is enlarged as ampulla, and the epithelium is reduced to simple columnar epithelium, and the muscle layer is reduced to only 1 layer. It receives the excretory duct from vesicular gland, from seminal gland, which is called an excretory duct, line again with simple columnar epithelium. And when these two ducts join, they form an ejaculatory duct, which is already in the wall of prostate, so it needs no muscle layer, so there's no muscle layer. But we come to these the details of these later. So let's come back to epididymis and its external features. Didymis means twin. Epididymis means like a twin above. And you can see that the twin here with the head and body and a tail is not like a real twin. It looks like a lizard lying dorsally on the testis. So it has got 3 morphological parts. Inside, in the head, we have the 10 to 20 ductuli efferent testis, and then inside the body and tail we have only one called ductus epididymis. It is fixed, as I said, by 2 small ligaments to testis, superior and inferior ligament. On the cross section, we can see the remnants of the development. So this is so-called appendix epididymis, which is a remnant of mesonephros, of its duct, of the Wolffian duct, of the beginning of the Wolffian duct. Then in the head, we can see the testicular efferent testicular ductules or ductuli. And then this is the surface of testis itself. So tunica albuginea and vasculosa, and then finally seminiferous convoluted tubules. So when you come closer, you can nicely see very high columnar epithelium. And on this here you can see the muscle layer, and then the adventitia forming the interstitial tissue. Coming closer, very, very beautiful view of the lumen containing sperms. So you can see the sperms here. Very high stereocilia, very high columnar cells. So it's a simple layer, but it's pseudostratified, as you can find here, the basal cells. So these are the basal cells. And below the basal cells, you can find the myofibroblasts and the collagen fibers of the tunica adventitia. So that's the ductus epididymis. Again, viewed from the slides of your old microscopes. So I think you cannot mix it with some other organs as such a beautiful epithelium you cannot see in other organs. Again, coming closer, you may think it's a stratified one, but when we come closer, especially to scanning electron microscope, we can see that the columnar cells are really going throughout the whole thickness of the epithelium. What about the blood supply of epididymis and testis as well? Of course, testicular artery is the main artery. It's an visceral paired branch from the level of L2, as the testis descend from this level during development. It enters from outside, so there is no hilum, but it then branches inside tunica vasculosa and sends vessels into tubuli from periphery. So that's difference in comparison to other parenchymatous organs. Then it is also supplied by ductus deferens artery, which is a branch from a umbilical artery, or sometimes directly from internal iliac. And a small contribution comes from cremasteric artery, supplying the cremasteric muscle. It's branched from inferior epigastric artery. And these 3 arteries forms mutual anastomosis. So they assure the blood supply of testes. But still, in case of torsion of spermatic cord, an acute abdominal attack can happen. So you can feel terrible pain in scrotum, and it has to be treated surely because it's an ischemic situation. Concerning the veins, both testis and epididymis are drained by pampiniform plexus. What does it mean? It's a venous plexus which is winding around the testicular artery, and the reason is to reduce the temperature of the blood coming to testes, so it takes the heat back to the body. Pampinus means a plant of vine, so it should remind you of a vine plant winding around a scaffold. And when it when it passes inguinal canal, it then changes into paired testicular veins, again with mutual anastomosis and valves, and they enter directly inferior caval vein on the right side, and because it's too far, so on the left side they drain in a right angle into left renal vein. And this angle on the left side, this right angle, can cause problems in drainage. So a varices can develop here. On 95%, it's on the left side, and it's then called varicocele. So varicocele varices mainly on the left side. In males, and it then can cause also a swelling of the left testicle. The lymph is drained again to the level of L2, so to the lumbar lymph nodes, and the innervation comes in plexuses around vessels. So we have a testicular plexus, which contains, of course, sympathetic fibers coming from celiac plexus, but don't forget about the vagus nerve innervation coming here, and it's the most caudal part of the body supplied by vagus nerve. And we conclude this part by developmental rudiments which can appear inside scrotum. So we can have a developmental rudiment even from the paramesonephric duct of Miller, which is reduced by anti-Müllerian hormone produced by Sertoli cells. And if it appears, it forms such a small cyst called appendix testis. We can have also an appendix epididymis, which comes from the Wolffian duct, or mainly from the mesonephric tubuli. So that's the appendix epididymis. And the mesonephric tubuli can also form such a separate organ. When it's separate, it's called a paradidymis, like a twin next to the right twin, called the Giraldez organ. Or it could form such a cul-de-sac, which in a shape of tubulus, which is attached to the ductus epididymis. Then it's called aberrant ductulus. So we can have these four developmental rudiments. They are usually asymptomatic, but they can change into a cyst and they can be enlarged. And it's necessary to distinguish them from a tumor. So the sperms are ready, and now during sexual arousal and the necessity of fertilization of a woman, they are released from the body by reflex. To get them from epididymis to penis, we use the so-called deferent duct, Ductus deferens. In the name, you can hear the word ferro. It's a verb, which means ferro means to carry. So the deferent duct means to carry away. It is a very long tube, 40 centimeters, and its lumen, it's very, very small, just 1.5 millimeters, and it is located inside scrotum, so it has got a scrotal part. Then it ascends inside spermatic cord, so it has a funicular part. Then it comes back to the trunk and enters the inguinal canal, so we have got the inguinal part, which is quite short, and then it becomes transverse in pelvis, which is very unique. No other structure is transverse in lesser pelvis. So we have the pelvic part. Then it turns around ureter, and it is located ventrally to ureter here. And it starts to enlarge and forms ampulla. Then the ampulla emerges with the excretory duct of vesicles gland or seminal gland. It forms very short ejaculatory duct having no muscle wall because it's located inside prostate, and it joins urethra, and they leave together prostate and they get into penis. So this is the deferent duct parts. And as I said, it crosses two important structures, ventral ureter, but before it also ventrally crosses the external iliac vessels, and it's located transversely in lesser pelvis. The old term vas deferens should not be used because it is not a vessel, not a vas, but it is a duct. As it's a duct, it contains, again, three layers of the wall. So the mucosa is formed by pseudostratified epithelium with stereocilia, and it's columnar one. As it has got very thick muscle layer during the rest state, or in your slides, it has got many longitudinal folds. When we come to the last part, to ampulla, this is enlarged and it has got many bays, many side eps, so we call them crypts. Then the muscle layer is very, very thick, 3 layers. And similar to urinary system, we have a longitudinal and circular, and then another longitudinal. If you palpate it, it's really, really tough. So it should remind you a goose quill, which was used also for writing in the time of ink. And the outer surface is covered in spermatic cord and in pelvis by a loose connective tissue, so adventitia. So a reflex transport of sperms from ductus epididymis to prostate is called emission, and from prostate further it is called ejaculation. So when we come to the sections, the transverse section shows you many folds and 3 layers of the muscle layer. So longitudinal, circular, and longitudinal. Yeah, you can see it's very, very thick. And the epithelium is columnar, pseudostratified with stereocilia. The stereocilia are not so nicely visible as in epididymis. You can hear very, very thick muscle layer, yeah, with 3 layers, longitudinal, circular, and longitudinal. And in adventitia on the surface, the vessels which supplies it. This is the pampiniform plexus in spermatic cord already. We can see also here some nerves coming. So this is the deferential plexus. And another view, again, very, very thick muscle layer, so you cannot mix it with some other organs. And pumpiniform plexus on the side. And this muscle layer, that's already the cremaster muscle. So we are again in a spermatic cord. And again, the details, and we can come to the epithelium again in detail. And maybe here the 3 layers of the muscle. Yeah, nicely visible the middle circular layer. And when we come here, basal cells and columnar cells. Yeah, the stereocilia are not well visible. So this is a pseudostratified columnar epithelium with stereocilia. And here again, nice columnar cells. Nice basal cells and the columnar cells here. And stereocilia can be visible in this higher magnification. And the last view of the 3 layers of the smooth muscles of ductus deferens. And when we come to ampulla, you can see that in ampulla there are many these side spaces which we call crypts. So this is the ampulla, the terminal part of deferent duct. How it's applied, even it's a very long tube, it is mainly supplied by ductus deferens artery, which is branched from the umbilical artery, and it is drained by pumpiniform plexus. But as it enters prostate, it is located on the posterior wall of urinary bladder, so it's also drained by vesical venous plexus, and that's why the lymph is drained into external and internal iliac lymph nodes, not to lumbar as the testis. And the nerves forms a deferential plexus along the artery. So the deferent duct is located inside spermatic cord, and the spermatic cord contains some covers. And the covers are derived from anterior abdominal wall during the development. As the testes descend through the inguinal canal, it takes all the layers. So, of course, skin. Then, if you remember, we have the scarpas fascia. The scarpas fascia is not the real fascia, you know, that is the membranous layer of the subcutaneous tissue. So then the scarpas fascia is also here, but in a form of so-called tunica dartos. What is it? It is a connective tissue without adipose tissue. So that's the difference in comparison with the anterior abdominal wall, but it contains smooth muscle cells. These smooth muscle cells are important for contraction. When a male comes to a cold environment, then what we need is to get the testicles closer to the body, to prevent the season of the spermatogenesis due to too cold environment. So what we use is a cremaster muscle, which is derived from internal oblique and transverse abdominis muscles. So it retracts the testis closer to the body, and also the tunica dartos causes folding of the spermatic cord and mainly scrotum. So that's the scarpas fascia. Then the superficial abdominal fascia continues here, so it's called external spermatic. We talk about the cremaster muscle coming from the muscle layer, and then the transversalis fascia also then produces another fascia from the internal surface, which is called internal spermatic one. What is the content? So the content is the deferent duct with its artery and a vein in the form of pumpeniform plexus. Of course, the testis is supplied by testicular artery and drained by pumpeniform plexus. Then we have the cremasteric muscle supplied by cremasteric artery and drained by cremasteric vein, because they both are branches from the external iliac artery axis, so from inferior epigastric vessels. Of course, the nerves come here as the deferential plexus and testicular plexus along the arteries. I'm sorry, this means nervous plexuses. We need lymph vessels, which drains along veins to corresponding lymph nodes. And as I said, during the development, a pouch from coelomic cavity appears, and this pouch is then called vaginal process. And the vaginal process produces the vaginal cavity of testes, and a communication or connection with the peritoneal cavity is then reduced and fades out, and there can be only remnants in the form of connective tissue, so it's called the vestiges. These remnants can stay here in a form of cysts, so they can be enlarged, and it is necessary to distinguish them from tumor or from varicocele. So please remember that we have here vestiges of vaginal process of peritoneal cavity. So when we come closer to pumpeniform plexus, we can see it here, surrounded by a bit of adipose tissue. Don't forget that this adipose tissue is not under the skin, but can be inside the spermatic cord itself. And we continue to another gland. We talk about the ampulla, which is the terminal part of the deferent duct. And the ampulla then joins the excretory duct of this seminal or vesicles gland. The seminal or vesicles gland, the vesicles gland should be preferred. It doesn't produce semen itself, but just the fluid, majority of the fluid, 70%. Develops as a pouch from the mesonephric duct of Wolff, which is a precedent to deferent duct and also precedent to a seminal gland. The seminal vesicular gland is 5 centimeters long and 2 centimeters wide. It's located behind the urinary bladder, and it's one coiled duct. Many times coiled duct. It's quite long, 15 centimeters long duct. And it's not only coiled, but it also contains 3 generations of folds. So we have primary, secondary, and tertiary folds inside. You can see also the location. It's laterally to deferent duct. So it's in posterior wall of urinary bladder, laterally to duct, and it's in contact with peritoneum. The most caudal part of peritoneum, which is located here. And that's called the rectovesical pouch of Proust. So the most caudal part of the peritoneal cavity is in contact with the tips of this paired seminal gland. Inside it's covered with epithelium, which can have 2 rows, so it can be pseudostratified, but mainly it's only simple columnar epithelium, but there are no stereocilia unlike epididymis, ductus deferens. The muscle layer has got only 2 layers, but they are very, very thin, circular and longitudinal, not well distinguishable in the slides. Notice the function of this many times called tubule. The function is to produce fluid, which is alkaline. So this alkaline environment causes stop of movement of sperms, because the sperms now are moved passively. So it is not necessary for them to use their energy. And to bring them energy then for the movement, it's full of fructase. It's full of fructose. Yeah. It also contains prostaglandins, which elevates the contraction of smooth muscles inside the female genital organs, so mainly in uterus and uterine tubes. And it also produces seminogeline, and seminogeline temporarily elevates the viscosity of the seminal fluids of sperms, so they do not move so well. So you can see that the function is to produce a vehiculum, so a fluid for the sperms to flow, to allow them, to give them energy, but to stop their movement, which can be here useless, as it's still inside the male genital organs. So when we come closer, you would not guess that this is one many times called tubule, and you can see the branched secondary and tertiary folds. And the epithelium is mainly, as you can see, it's mainly columnar and simple. When we come closer again, you can see it here. Maybe you would say, oh, I can see a gallbladder, but the gallbladder cannot have so many lumina, even there are very nice folds. And this is a muscle layer, and I think you cannot distinguish 2 layers of the muscle layer here very well. And again, the muscle layer here, and the simple columnar, sometimes you can see it's double, so the basal cells can be visible as well. And this inside is just a remnant of the fluid, of the semen. And this is a view from your microscope, so don't forget, on the surface, very thin, double-layered muscle, and then one many times called tubule. And when we come closer, columnar epithelium, no stereocilia, sometimes a basal cell. So that's all for the seminal gland, and we move to prostate. Prostate is the second accessory male genital gland, and it is located below urinary bladder, and it's totally different from the seminal vesicles. As you can see, its shape, it is pyramid shaped, but inverted upside down, and it's located behind pubic symphysis. So you may remember that here we have a retropubic space of Retzius, and it contains loose connective tissue, and here vein, dorsal vein of penis, which enters this space from below and forms here a plexus, and is the pudendal plexus of Santorini, which then continues in the prostatic venous plexus. Dorsally, it borders rectum, and it's divided here from rectum by rectovesical septum. So here's a rectovesical septum. Here's a section through seminal gland, which is in touch with peritoneum here, so with the bruised rectovesical pouch. So the prostate contains then urethra, and the urethra accepts here deferent ducts and excretory duct from a seminal gland, which then join into so-called ejaculatory duct. So the prostate is quite small. It should weigh only 20 grams, and its diameter should be 4 to 3 to 2 centimeters only. It has got a base similar to the heart. The base is cranially and the apex is caudally. Isthmus is visible only on section, I will show you later, and we can distinguish three surfaces: anterior surface towards symphysis, posterior surface towards rectum, and inferolateral surface. That's the surface you can see here, and it's adjacent to pelvic floor muscles, to levator ani muscle. We can divide right and left lobe, and during development, several lobules, but they disappear at the week 20 during the intrauterine life, so not important to know. And then we have a middle lobe, but the middle lobe is again visible only on the section together with isthmus. Inside is the male urethra, so the prostatic part, which we can distinguish into proximal and distal. Proximal contains only urine, and distal is below the opening of the ejaculatory ducts. So it can transmit urine or semen. So the ejaculatory duct, which opens here, is quite short, quite narrow, and contains no muscle layer. So again, we can see it here and in detail. This is the ejaculatory duct. And what can we see inside the urethra? If we open the urethra, we can see an elevated ridge, which is called urethral crest. That's the elevated ridge. The elevated ridge is enlarged in the middle in so-called seminal colliculus. Colliculus means a little hill. And on this little hill is the opening of ejaculatory duct, which is paired. And then this unpaired larger opening, which is called prostatic utricle. Prostatic utricle, sometimes called the male vagina, is a remnant of Müllerian duct. We said that the Müllerian duct disappears by means of anti-Müllerian hormone produced by Sertoli cells. And there can be two remnants on the very ends. The very beginning is the appendix testis, which I showed you in scrotum as a rudiment. And on the opposite side, so very close to urogenital sinus, the remnant is here, and it's called prostatic utricle. So it's just a developmental remnant. So we have here these three openings. So prostatic utricle, unpaired, and paired ejaculatory duct opening. And then on the sides, where are such a ditches. So this paired ditch is called prostatic sinus, and it contains here these small openings. These small openings are called prostatic ductuli, and they are openings of prostatic glands. So the prostatic glands opens here to this prostatic sinus. We have three types of glands based on their position. So we have very small and short mucous glands. Then we have deeper submucous glands, and we have principal glands. The number of the glands is higher than the number of the ductuli because their ductuli merge. So that's the internal morphology. Here on this median section, we can see the median lobes. I said we have right and left lobe. And on the section, we can see this median lobe, which is located between urethra ventrally and ejaculatory duct dorsally. How the prostate is fixed? It is, of course, maintained from below by levator ani muscle and its subpart called puboprostatic muscle. There exists also a vesicoprostatic smooth muscle, but it is not very important. Prostate is below urinary bladder, so it's totally subperitoneal organ, and it's located above both pelvic floor and urogenital floor. Now we come to the histological structure. When we perform a transverse cut, we can see isthmus. So isthmus is this ventral part which contains no glands. So that's isthmus of urethra. And now we come from externally to internally. As it's a subperitoneal organ, it has to be covered by some connective tissue. And this connective tissue is a part of visceral pelvic fascia. So sometimes it's called also periprostatic capsule because it's not part of the organ, it's just the connective tissue between this organ and the other organs. So it can be also considered an adventitia. Then we come finally to organ itself. So because it's a parenchymatous organ, it has got a capsule. But this capsule has got fibrous layer, which is in the middle, a thin, smooth muscle layer below, and superficially, so between the fibrous capsule and the pelvic fascia, we have vessels. And you know these vessels, prostatic venous plexus. So the prostatic venous plexus is located between the visceral pelvic fascia and the fibrous capsule itself. Then we come to a specific structure of the prostate. It's called fibromuscular stroma. It's a parenchymatous organ, so it has to contain a stroma, and this stroma does not form any septa. It forms a really scattered structure, like irregular one, and it's composed of connective tissues and muscle cells, which is smooth muscle cells, which is very specific. And this also allows the glands to be emptied during ejaculation. So there's the fibromuscular stroma, unique for prostate, and then glands. And these glands, which are arranged, as I said, as mucosa, mucosa, and principal, histologically are branched tuboalveolar, and they drain into urethra. So here on this slide, we can see a section, transverse section, stained by hematoxylin eosin. In the center, what is visible is the seminal colliculus, and the seminal colliculus opens into urethra. Then we have here two ejaculatory ducts, and this isthmus, which contains no glands. On the surface, we can see the capsule, and then when we look closer, we can see the area of glands here, but then the areas of glands also located here. And based off unequality of these parts, the prostate can be divided into sub-zones. These zones were defined by McNeil, and we have 5 of them, and they are very clinically important. So we talked already about isthmus, which is ventrally. There are no glands, so it contains only fibromuscular stroma. So the isthmus, when we come closer, was here. Yeah, isthmus. On the contrary, the majority of the gland here is filled with glands. So we call this a peripheral zone. Majority means 70%. It's located externally and it contains so-called main glands, principal glands, glandulae principales. So it's called peripheral zone, or anatomically, according to the real location, it's called infero, postero, lateral zone. But we prefer to use the more clinical terms, so peripheral zone is fine. Then we have so-called periurethral gland zone. So it contains the mucous glands, and it's just very superficially located. So it's located inside the muscle wall of urethra. So when we come back to some figures, it's this area just around here. That's the periurethral zone, or here the violet one. Yeah? So the violet one is the periurethral zone. And then we have another two zones. Transition, which is between the periurethral and peripheral zone, only 5%. And central zone, which is also located between periurethral and peripheral, but in other location. It's located quite up around ejaculatory ducts, and both of them contain submucous glands. So when we come back here, so you can see the central zone and the transitional zone. So the difference between them is just the location. The central zone is located dorsally and cranially, just at the level of ejaculatory ducts. When we come a bit below, there is no central zone, then it's only the transitory zone. So we can come to figures which shows us the location. So then ventrally, no glands, so isthmus, anteromedian zone. Then cranially and dorsally, central zone with submucous glands close to or in the vicinity of ejaculatory ducts. Of course, periurethral zone, which is here. Transitional zone, which is ventrally. And the majority, 70%, is the peripheral zone. Again, some figures showing the same. So we can see here, letter A is the periurethral zone with the mucous urethral glands. Then we can see dorsally the central zone. So here you can imagine two ejaculatory ducts. Then ventrally we have the smaller transient zone with submucous glands, both of them. And very ventrally the part without glands, so we call it isthmus or anteromedian one. And what is the remnant? The remnant is the peripheral zone, 70% of principal glands. What is the function of the prostate? The function of the prostate is to form the remaining 30% of the semen fluid. The pH is also a bit alkaline, so it's also then stops the movement of sperms. Also, to stop the acrosomal reaction, very necessary is the production of the zinc. It also produces prostaglandins and some other components. But the most important components for us will be prostatic specific antigen on the surface, which also binds to the surface and stops the acrosomal reaction, and acidic phosphatase. Acidic phosphatase is one of the enzymes which is produced here necessary for metabolism of the cells, and it's a prostatic fraction of that because we have also a bony fraction of acid phosphatase. And these two are very important in clinics. I'll come to that a bit later. So which epithelium is here producing this secretion? It is epithelium which is simple, but the height of the cells changes. If there is no function, it's flat. If there is too much function, it's columnar. It's under the influence of testosterone, and the testosterone, when it comes here, becomes more active when it changes into dihydrotestosterone by enzyme which is called 5-alpha reductase produced by stromal cells. So the stromal cells are located in the fibromuscular stroma, and they supply the cells of the glands with a dihydrotestosterone which is more active. So these glands contains these main cells. The main cells produces prostasomes, and prostasomes are vesicles containing enzymes which merges with the sperm membrane to help to activate them as well. So that's the function of the principal cells in principal glands. We have three another types of cells here. Of course, basal cells, then some endocrine cells for paracrine secretion to regulate the environment here, and then cells producing sialomucin, which helps to protect the wall. What is typical for prostate is production of the concretions. These concretions are composed of glycoproteins, and they contain calcium, so they are X-ray positive. So you can see them on X-rays, you can see them on slides. So they are very specific. They are from 0.2 to 2 millimeters large, and they appear there from the age of 20. So that's the composition of the prostate. So if we come here closer, we can see the different glands. We can see the glands which are very, very close. So they are the mucous glands in periurethral zone. Then we can see the submucous glands in the central and transient zone. And we can see the main, so the principal glands in the peripheral zone, and on the surface is the capsule, and the space between is formed by fibromuscular stroma. So what is here? The most distinct structure is the prostatic concretion, yes, which you can nicely see here. These are just the histological process remnants, these stripes. What you can nicely see here in mesenteric, the fibromuscular stroma is shown. The red part is a smooth muscle cells, and the blue part are collagen fibers of the connective tissue. So this is specific to distinguish prostate from other organs. And when we come closer to some slides which you can see in your microscopes, the arrangement of prostate, it's not so beautiful tubuli or alveoli, but they are quite irregular shape that helps you to distinguish it. Also, there's quite abundant content of the fluid inside the glands. And when we come closer, you can nicely see the epithelium. And in this case, the epithelium is very high, so you have a simple columnar cell. So this is a very active prostate. And in between, of course, the fibromuscular stroma, which is here again shown by specific staining, showing you the muscle cells, smooth muscle cells, and connective tissue. And again here nicely the columnar epithelium and the prostatic fluid shown. Several more figures, and we move to scanning electron microscope, which comes not from a male but from a mouse. But we can see here really high columnar cells and vesicles, so the prostasomes, which contains the proteins necessary to merge with the membrane of the sperm. And here in the center, nicely visible protein concretion. So that's the prostatic concretion, and the epithelium here is not so high, as you can see. So here is just only cuboid epithelium, so this is not very active prostate. On the contrary, here columnar epithelium and basal cells here, and beautiful prostatic concretion. And another example of these concretions with a lower epithelium. So, to conclude prostate, we should talk about the blood supply. It's a gland, but it does not contain a hilum, and it is supplied by the adjacent vessels. So as it's located below urinary bladder, it is supplied by inferior vesical artery. As it receives the deferent duct via ejaculatory duct, it is supplied by Ductus deferens artery. And its inferolateral surface is lying on levator ani, and levator ani is supplied mainly by middle rectal artery. And the posterior aspect of prostate is adjacent to rectum, and it is divided by rectovesical septum, so it's supplied by middle rectal artery. It is drained by prostatic plexus, which is continuous with vesical venous plexus, and it drains into internal iliac vein. And of course, the lymph is drained into the nearest, so internal iliac and external iliac lymph nodes. But don't forget, it's located very dorsally, and it has close relationship to rectum. So it also drains into sacral lymph nodes, and from these sacral lymph nodes, it is quite close to sacral bone. So bony metastasis in the sacral area and low back pain can appear in prostate cancer higher stages. Because it's located inside lesser pelvis, it is supplied by inferior hypogastric plexus. The inferior hypogastric plexus sends prostatic plexus and then branches which runs along the prostate, and they continue down to penis. They are called cavernous nerves. Yes. So the cavernous nerves, they are very important as they run here. And if you want to remove prostate due to cancer, it's very important to keep the nerves and do not harm them. So removal of the prostate, sparing these nerves, is now called a nerve-sparing radical prostatectomy, and after removal, the erection is assured to the patient. So please remember that the cavernous nerves are in very close contact to prostate. And now why we have talked about the zones. There are two clinical diseases which are closely related to these zones. First is benign hyperplasia, sometimes called hypertrophy, but it is important that it's multiplication of the gland, so it's called hyperplasia. You can see that it affects 50% of male above age of 50. And it concerns mainly hyperplasia of submucous glands. That means glands in transitional and central zone. Why? Too much activity of 5-alpha reductase in stromal cells, and then too much dihydrotestosterone causes hyperplasia of the glands. And what happens when these two layers are larger and larger? It firstly closes urethra, so it reduces its lumen, and it produces retention of urine and problems with voiding of urine. And it also compresses the peripheral zone to the sides, and the peripheral zone and the fibromuscular stroma in it then forms a very tough capsule, which is called a surgical capsule. So you know what is the anatomical capsule? Yeah, periprostatic, formed by visceral pelvic fascia, then the vasculose layer formed by prostatic venous plexus, the fibrous layer, and the smooth muscle layer. And that's the anatomical capsule. And then the peripheral zone with the fibromuscular stroma is compressed, pulled to the side. And for the surgeon, it creates an imagination that there's a real capsule. But this is not a capsule, it's just a compressed peripheral zone. How to treat it? Of course, you can apply the 5-alpha reductase inhibitors, and in case it does not help, you need to remove the prostate surgically. So you have two ways. One is to put a catheter into urethra and to enlarge the lumen. So you really drill the lumen and you extend urethra, or you can open urinary bladder from ventrally through. You go extraperitoneally through the retropubic space. You open the urinary bladder, and then you can remove from inside the urethra, but you let the capsule in the position. So you just remove the parenchyma, not the capsule. In case of malign adenocarcinoma coming from the zone, from the principal glands in peripheral zone, on the contrary, you need to remove the whole gland. Usually there are not the problems with urination. And how you can recognize it? First is palpation via rectum, but mainly ultrasound, either via rectum or via perineum. And in blood, you can measure the level of the prostatic fraction of the acid phosphatase, but mainly prostatic specific antigen in blood. Yeah, so it is necessary to measure it and then to continue measuring and checking the differences in the level. So please remember, benign hyperplasia in the transient and central zone, and malign carcinoma mainly in peripheral zone. So how to examine? Mainly ultrasound, either via rectum or directly via perineum. And what you see is a homogeneous structure of prostate. You can see in urinary bladder the urine. And if the prostate is not nice, you can see the white calcifications, or this quite dark structure, which is an adenoma of prostate, non-malign, but still a dangerous situation. What also can be performed is a seminal vesiculogram. So via penis and urethra, contrast dye is instillated, and it goes through deferent duct to its ampulla and ejaculatory duct, which is then connected here to seminal gland. So this is performed only in cases of problems with the reproduction. So to find out what is the cause of a non-fertility of a male, if it can be maybe the not opened excretory male genital tract. And the last accessory male genital gland is the bulbourethral gland of Cowper. It's a very small gland located inside urogenital floor, so below pelvic floor, very small, so pea-sized, up to 1 centimeter big ball, and it is a compound mucinous tubular gland. So it contains again simple columnar epithelium with the main secretory cells and some paracrine endocrine cells, featuring a short duct with stratified columnar epithelium and some goblet cells, because now we are in urethra, so we need also the goblet cells to produce mucus. And it opens into male urethra. It opens already into penis, and its called ampulla because it's a bit enlarged. The product is called pre-ejaculate, and the function is to lubricate urethra for ejaculate to easily pass. So its component is mainly galactose and sialic acid. So that's Camper's bulbourethral gland. And let's look where the gland is. So it's located really here, inside the perineal muscles from below, and it's located dorsally to urethra, and it opens into ampulla, and the ampulla is this part here. This is the ampulla of the spongy part of the male urethra. And on the section, you can see these tuboalveolar arrangement with ductuli, with stratified columnar epithelium, which is similar to the epithelium of spongy part of the male urethra. So, and continue with the male urethra. Unlike the female urethra, it's longer, up to 20 centimeters. It's narrower. It is twice curved. And it is narrowed at some places more than in the other. So it originates as an ostium inside the urinary bladder, and then it continues as the intramural part, and it enters prostate. So when we come here, you can nicely see its parts. So the internal ostium here, and a very short intramural part. So this is a narrowed part. Then it's enlarged in the prostate. But in prostate, it is enlarged in normal state. But in case of hyperplasia, this is the most narrowed part of male urethra. So please remember, in half of the males above 50, you have to expect the most narrow part being within prostate. Then we can move further, and we enter the pelvic floor and urogenital floor. So we call this intermediate part or a membranous part. In this area, the smooth muscle layer is replaced by skeletal muscle layer by external urethra sphincter. And then we enter the spongy body of penis. So we have the spongy part, pars spongiosa, and it starts with ampulla and terminates with navicular fossa. So let's look how they look like. So the ampulla is the beginning in here, where the bulbourethral gland opens. Then you have a very narrow spongy part. So that's another narrowing. And then we have this enlarged navicular part. In this navicular part, you can see this septum. And it's a valvule. It's a remnant from the development, as during the development an ectodermal bud grows here inside and form this. So this ectodermal bud then illuminates, and so there's an opening, and during luminization such a blind recess can develop here. So don't forget that this valvule can be found here. And then we terminate with the external ostium. So we have 4 constrictions, 4 narrowings. Intramural part in the wall of urinary bladder. Intermediate part when passing through pelvic floor and diaphragmatic floor. Urogenital floor. Then very long spongy part inside the spongy body of penis. And then the opening at the very end of at glands, the external ostium of urethra. Of course, there are 3 enlargements: prostatic part, ampulla, and navicular fossa, and the prostatic part can be the most narrowed part in old males. Clinically, we have anterior and posterior urethra, and the division is when exiting from the pelvis. So this is then anterior, and this is clinically, back. Of course, this has to be posterior because it's based on catheterization. So that's the anterior urethra, and when you enter the pelvis, it's the posterior urethra. So concerning epithelium inside, it's a bit complicated. So the intramural and prostate part then contain transitional epithelium, so the same epithelium as in the excretory urinary system, so calyces, renal pelvis, ureter, urinary bladder. And then when we come to ampulla and spongy part, it contains the stratified columnar epithelium. And the stratified columnar epithelium then continues to the very end, to the ectodermal bud. So now the navicular fossa, when it changes into stratified squamous non-keratinizing epithelium, and when it gets on the surface of the glands through the external orifice, it changes into keratinizing stratified squamous epithelium. So 4 types of epithelium in male urethra of different length. Inside the urethra, of course, we have small glands. In prostate, we have to talk about the mucous glands in periurethral gland, yes. And then in spongy part, we have also these glands, which we call urethral glands of Littre. They are so-called tuboacinos, so they are a bit different than the typical tuboalveolar ones. And you may remember we have tuboacinous glands, for example, in trachea. And they also serve for the lubrication, so the function is similar to the function of Cowper's glands. And in the wall of urethra itself, in epithelium, we have the intraepithelial mucous glands, so just the clusters of the cells. And they form, similar to female urethra, they form small pouches, which are called lacunae. So the Morgany's lacunae are intraepithelial mucous glands. As I said, there can be found valves, inconstant valves or folds inside. They are not real valves, but they are called in clinics valves. And they can be the problems in catheterization. And the constant one is the valvule in navicular fossa. So if you want to perform catheterization, you have to first put the penis into horizontal position. So this prepubic curvature is then straightened. And then if you enter the external orifice, you have to go this way. Otherwise, you come into the navicular fossa, which you don't want, into this blind recess. Yeah, so you don't want to get into this area. No. So you go here towards the body in a straight penis, so this way. And then, of course, there's the second curvature, subpubic one, and then you have to get in 20 centimeters long catheterization. So we have talked about the male urethra, and now we continue into the penis. Penis is an erectile copulation organ composed of several parts, composed of three cavernous or erectile bodies. Two are cavernous, they are paired, so you can see one here. So it's the paired one. And the part which is grown together with the phallic crest of inferior ramus of pubic bone is called crus. And then the unpaired part, which is called spongy body, and it's composed of glands. And on the other side of a bulb. And it contains the urethra inside, from ampulla to navicular fossa in glands. So these are three erectile bodies, and the penis as a whole has got here a root, and then a body, and then a glans. It has got two surfaces, dorsal surface and urethral surface. The dorsal surface is this one, that's the dorsum, and the urethral surface is this one. So during the development, how the urethra develops and the penis. So we have a indifferent genital stage, and it contains this phallic or genital tubercle. Then it contains these, and the small and the big folds. In female, you can nicely recognize the clitoris here, the major labia here, and the minor labia here. In male, it changes. The tubercle, the phallic or genital tubercle grows into penis. These outer folds, they are called labioscrotal folds, so they form scrotum. And these internal ones are called urethral folds. So these urethral folds form urethra. They grow together. If they do not grow together well, then urethra can open pathologically, open to the urethral surface, so like this. And then it's called the hypospadias. And in most common most common male developmental defect of the urinary system, hypospadias. Based on non-fusion of these two urethral folds during the development. So this is the urethral surface, dorsal surface. It can also open the urethra pathologically here on the dorsal surface. That is not so common. It's quite rare. It's called epispadias. Epispadias. And why it happens? You may know that the anterior abdominal wall, its inferior part, fuses from the sides like this. If it does not fuse, it can produce a developmental defect called gastroschisis. If it fuses only a bit, it can produce an extrophy of urinary bladder. So the urinary bladder also opens ventrally. And the least severe version of this is just an opened urethra on the dorsum of the penis, which is called epispadias. So that's why we should know something about the dorsum and urethral surface. And then we come to skin, which covers the glands, which is called prepucium. So we have the skin covering the gland. If the prepucium cannot be moved from the glands, it's necessary to remove it surgically, and it's called a circumcision, and it's mainly performed in Israel and Arabic countries from ritual reasons, but it is very good to perform it due to hygienic reasons as well. Because the penis grows from our left and right side. In the midline we have a raphe, which is continuous with the raphe of scrotum. So what is inside? Inside, on the transverse section, we can see on the two cavernous bodies, and the cavernous bodies, the paired cavernous bodies are perforated, so the septum is incomplete, so the blood and also the lymph can flow from the left to the right one. Both are covered by so-called tunica albuginea, again a whitish tough connective tissue, which serves us as a tough structure during erection. It sends trabeculae inside, and this trabeculae form spaces for blood, which are called caverns. We have also here the spongy body with the thin tunica albuginea, and also with trabeculae and caverns. It is covered by two fascia, the deep and superficial. The superficial is continuation of the scarpus fascia, so it's only the membranous layer of the subcutaneous tissue, and the deep is the continuation of superficial abdominal fascia. So then it continues on spermatic cord as the external spermatic fascia. How it's fixed? It's fixed by two ligaments. One of the ligament is visible here, is the suspensor ligament. And in case you see an advertisement, a prolongation of penis, what they do is that they just cut this ligament, and the penis in a relaxed state is a bit longer, but in erection it is not long anymore, and it is not so stable. So any prolongation of penis is just a wasting of money. Another ligament is fundiform ligament. It's located in this area, and you can see it reminds you of a loop which encompasses the whole penis like this. And of course, it's fixed. The crura penis are grown together to phallic rest of inferior ramus of pubic bone, as I said. So a transverse section of the penis, you have to know how to grow it, how to draw it. So again, we have here the cavernous body with the deep artery of penis. Don't forget the septum and the tunica albuginea, which is this one, separate for cavernous bodies and separate for spongy body, which contains a urethra and a paired urethral artery. Then you need to cover the structure with the deep buccal penis fascia and superficial fascia, which is the subcutaneous layer of, which is the membranous layer of subcutaneous tissue. Then you have to add the dorsal penis artery, which is paired, and unpaired deep dorsal vein and unpaired superficial dorsal vein. The superficial one drains into great saphenous vein. The deep one drains into pudendal plexus of Santorini and also into internal pudendal vein. So it has got two, it is really divided into two. And don't forget the nerves. Here are cutaneous nerves, which we call dorsal penis nerves, branches of pudendal nerve. And what we cannot see are the cavernous nerves, which we spared during the radical prostatectomy. They are already divided inside the cavernous bodies. So that's the transverse section which you should learn to draw. So the blood supply comes from internal pudendal artery, giving the paired deep artery, paired dorsal artery, paired urethral artery into the spongy body, and paired a bulbar penis artery only for the bulbus, which is not visible in the section, as in the section was just in the middle of the penis, not in the root. The arteries inside spongy body and the cavernous bodies, they ramify into so-called Helicinae arteries, which contain intimal cushions called von Ebner's cushions. I will come to them later. And then from the caverns, it's drained by cavernous veins into superficial, unpaired superficial dorsalis penis vein, which drains into external pudendal vein, great saphenous vein, common femoral vein, and external iliac vein. Then the unpaired deep dorsal penis vein, which bifurcates, which is quite unique to veins, because we know that what bifurcates is the hepatic portal vein into right and left, or retromandibular vein. These two bifurcate, so now you know the third one. So it bifurcates, and one branch gets through, or better, between pubic symphysis and urogenital and pelvic diaphragm. It gets into lesser pelvis, into pudendal plexus of Santorini, into retropubic space, and the other joins internal pudendal vein, as well as the veins of bulbous penis and the urethral vein. So the main drainage is internal pudendal vein, but it also drains to pudendal plexus and to great saphenous vein. Concerning the lymph drainage, it follows the veins. So it goes into internal iliac from the deep, but from the glands and from the skin, it goes to inguinal. From the glands directly to deep, but from the skin, which is the most important for carcinoma, it goes to supermedial part of the superficial inguinal lymph nodes, and we have here so-called sentinel lymph nodes, called Cabanas lymph node. So if you palpate an enlarged lymph node in a male superomedially to in the groins, it is suspectly positive Cabanas lymph nodes, and there's a suspicion to carcinoma of penis. The innervation is by pudendal nerve to the skin, and of course we have sympathetic fibers and parasympathetic fibers coming from inferior hypogastric plexus. And gland penis and gland clitoridis are, together with cornea, the most richly innervated areas of the body, and concerning the skin, it's just glands. So what you can see here is the histological non-stained section of the penis with three cavernous bodies, yeah, right and left. Cavernous here and the spongy body here with the urethra. And the tunica albuginea thick around the cavernous bodies and thin around spongy body. And then here you can see the blood vessels on the dorsum and the skin and subcutaneous tissue. Here, in case we make a draw of the male of the male urethra and its gland and epithelium. So transitional epithelium, it's in the first two parts. Intramural and prostatic. In a membranous or intermediate part, it changes into pseudostratified columnar epithelium, and it continues to glands, to navicular fossa, where we have a stratified squamous non-keratinizing, and in external ostium, it changes into keratinizing. So here we can see the tuboacinar gland of Leydig. So these are the urethral glands of Leydig. So you can see nicely the acinus, but the acinus contains mucous cells, not serous. And here is a monkey, and a slide of a monkey penis with nicely visible incomplete septum in this area, and the deep vein of penis inside cavernous body. And again, a section through two cavernous bodies and one spongy body with a beautiful urethra. And now a principle of erection. The erection is parasympathetically based, and ejaculation is sympathetically based. So after sexual stimulation, which can be either based on skin receptors or based on visual or auditory stimulation, so then the brain cortex is stimulated, and via hypothalamus spinal cord we come to S2 to S4 area of spinal cord, where is the pudendal onus nucleus, and it elevates the tone of parasympathetic system via pudendal nerve coming to the penis, where the production of nitrogenic oxide starts, and this produces a relaxation of the smooth muscle cells inside the sinusoid walls, and the intimal cushions of von Ebner are relaxed and lowered, so much more blood comes into the caverns. It also compresses the efferent venules, and also the smooth muscles in the tunica albuginea are stretched, so then the erection is formed. The erection of the termination of erection starts when the phosphodiesterase starts to be active, and this can be blocked by sildenafil, which is commercially produced as the blue pill called Viagra. So that's the principle of erection. And then the ejaculation continues from the sympathetic areas in T11 to L3, and it produces 2 to 5 millimeters of ejaculate, which contains up to 200 millions of sperms with alkaline pH, which is then changed, of course, in acidic to acidic pH in a female genital tract due to acidic environment in a vagina, which then activates the sperms. A normal spermiogram should contain at least 4% of normal sperms, and there should be at least 15 million sperms per 1 milliliter. And we continue to the last organ, which is scrotum. Scrotum is just the sac containing 2 testicles. It is divided by complete septum. It is formed by 2 labioscrotal folds, which grow together. So that's why we have a raphe there. The wall is formed as the same way as the wall of spermatic cord. So it's formed by derivatives of abdominal wall, and it contains skin, which is more pigmented with many sweat glands, which also helps to lower the temperature. And there are no adipocytes, again, to not to isolate a scrotum from around. There are, of course, some sebaceous glands and hairs, and the tunica dartos contains myofibroblasts. The blood supply is similar to penis, so we have anterior and posterior scrotal veins draining into great saphenous and internal pudendal vein. And of course, for arteries, we have pudendal artery and the external pudendal arteries, which are branches from the femoral artery. So from 2 axes, it can also serve as an anastomosis between network of internal iliac and external iliac arteries and veins. The innervation comes ventrally from nerves in inguinal canal, so it's ilioinguinal and genitofemoral nerves, but majority comes dorsally from sacral plexus, from pudendal nerve, and also close to perineum from posterior femoral cutaneous nerve and its perineal branch. The lymph drainage is very, very important as it develops from this area, from the end of trunk. Unlike testes, it is drained to nearest lymph nodes, which are superficial inguinal lymph nodes. But the testes, which descended from the level of L2, it drains into lumbar lymph nodes. So in case you have a suspicion of a tumor in testes, you would perform puncture, but not in this case. In suspicion of this, you just remove the whole testis. Otherwise, during puncture, you can spread by the needle the tumorous cells from testis to scrotum, and you then would involve another large layer. So then the tumor is not only in testis and lumbar lymph nodes, but also in inguinal lymph nodes, and that means the external lymph nodes, the deep inguinal lymph nodes, external iliac, common iliac. So you spread the cancer, and you will terminate the life of the patient quickly. So what is the structure of the scrotum? Layers, as the abdominal wall, of course, skin. There is no fat, so there is also not Kemper's fibrous layer which holds the fat. There is very thin continuation of the scarpous membranous layer or scarpous fascia as the myofibroblasts. So that's the tunica dartos, when dartos means in Greek scrotum. And then we have the cremaster muscle, which is derived from internal oblique and transversus abdominis muscles. So it's here covered with some connective tissue called cremasteric fascia. and it is covered by superficial abdominal muscle derivate, which is called external spermatic from outside, from inside, transversalis fascia derivate, which is called internal spermatic fascia. And don't forget about the vaginal process of peritoneum, which forms the vaginal tunica of testis with 2 layers, parietal and visceral. And to terminate this, we have to talk about the urogenital floor muscles. The urogenital floor is not an official term, but we really like it because majority of the muscles form really a plate. That's why a floor. So we call it officially perineal muscles. And 4 of the muscles form a floor. And then on the floor, on the top of the floor, we can find one muscle in male, and it's the external urethral sphincter. And the very center is called perineal body, and it's composed of smooth muscle layers, striated muscle layers, but mainly connective tissue. So now from below, we can see here in this figure coccyx and sciatic tuberosity, so tubericiadicum here. So this is a sacrotuberous ligament. Anus, and this is levator ani. So here we look into so-called ischioanal fossa. And this is called anococcygeal ligament or anococcygeal body. The area of interest is located ventrally, and it is so-called bulbospongious muscle because it forms here the cluster of skeletal muscle cells along the bulb of penis and the spongy body. We have the ischio-cavernous one, which comes from the sciatic tuberosity or ischial tuberosity along the ischiopubic and phallic crest to cavernous body. And then we have this, which is the deep transverse muscle, and it forms the majority of the floor, such a triangle here, deep transverse perineal muscle, and very thin and quite useless superficial perineal muscle. So you have 4 paired muscles, and what we cannot see because it's above it is the external urethral sphincter. So these are 5 muscles, or 5 perineal muscles or muscles of the urogenital floor. Their innervation comes mainly from S4 via pudendal nerve, but because during ejaculation there are reflex contractions, it's also supplied by sacrosplanchnic nerves, which are autonomic. And here is just what the students do when they are bored with the urogenital system. They can see some extraterrestrial guys having the head of penis section. So please, during the study, of course, relax, but don't forget to learn the section of the penis and all the other information. Thank you very much for the attention and have a nice day. Bye-bye.